the questions posed in that.
Well, good morning, everyone. Today we welcome Dr. Bertagnoli as our to our subcommittee for the first hearing as the director of the NIH. As always, I know along with my colleagues, we look forward to learning more about the scientific research that's done at NIH and the investments that are made there, and especially the investments in gene immunotherapy, revolutionizing cancer treatment. Also cures and prevention for early stages of diabetes, and the diagnostic testing and imaging that can catch the progression of a disease when there is still time for it to change course. And no doubt every life is touched by the discoveries made by the investments at the NIH. I think that goes without question. It is the high value placed on NIH discoveries that make me disappointed to say that the NIH is the only entity within the Department of Health and Human Services that has not released an assessment or even made an acknowledgement regarding some of the failures in regard to the COVID pandemic. For many of the American public, trust in the institution is gone, and once lost, it will take great effort to restore. I would encourage you to put as a top priority rebuilding the confidence in the NIH as a leader in unbiased, nonpartisan, objective basic science. It is that history of research that has helped support medicine and that have saved countless number of lives. Annual funding to NIH, more than $48 billion, was given last year, larger than the annual gross domestic product for half the world. The magnitude of the investment showcases the importance of America's that we place on being the world's leader in research and in innovation. I know it is critical to our nation's security that America remain that leader. China's 1,000 Talents Program and outsized investments in biomedical research are clear dangers to our national interest. Combating foreign interference at our research institutions should be a top priority. and I want to let you know that you have our support. I look forward to learning more about NIH's efforts to protect security of data and intellectual property. In the current global environment, concerns over foreign influence on U.S. biomedical research have intensified. This committee's appropriation bill prohibits certain foreign entities, including the Wuhan Institute of Virology, and any lab owned or controlled by the government of China, Iran, and Russia from receiving funds for conducting research due to the risks they pose to the American safety and security. Despite increased efforts by the NIH to combat foreign influence in biomedical research, failures related to foreign influence persist. In 2022, the Department of Health and Human Services Inspector General issued a report and evaluated how the NIH grantees ensure that investigators disclose all foreign interest and support and review this information prior to reporting the information to the NIH. The OIG found that investigators, in some cases, neglected to disclose substantial foreign contributions, undermining the research integrity. The OIG also found that most grantees failed to meet at least one federal requirement related to our investigators' foreign financial interest and support. In addition, the OIG determined that many grantees lacked oversight practices that would help ensure that all materials submitted to the NIH were complete and were accurate. The OIG's recommendations were basic management practices. Ensure investigators are trained, have clear disclosure policies, and they would validate reports. Very simple, very necessary, and certainly overdue. Yet, it has been 2 years since that report was published, and the recommendation that the NIH modify reporting mechanisms requiring grantees to report financial interest and other support involving foreign entities remain unimplemented. Oversight of the grant funding given out by the NIH is paramount. Another top concern is also the range of research institutions receiving funding. 10% of the institutions get 75% of NIH funding. And I think to most everybody here, and I think most Americans, that's really unacceptable. These are the same elite institutions that saw campuses overrun by lawlessness and anti-Semitism. Much of this funding is not supporting basic science and research, but instead supports an ever-growing higher education administrative state. I support your efforts to increase funding for lower resource institutions and expand the base of schools receiving basic research grants. I also want to encourage you to exercise caution when determining your research portfolio. There is no need to wade into controversial research agendas. One thing is clear, we are not going to build back the public's trust wading into controversial core mission of basic science. The NIH is not operating under a current authorization, making it one of the largest expired authorizations in government. In addition, it has been decades since Congress made a comprehensive evaluation of the institution's structure. We have been creating one institute, center, office, or agency piecemeal for over the last 10 years, adding but not strategically or reorganizing it. This year, in cooperation with the Committee on Energy and Commerce, we solicited broad input from research communities to engage on this very reform. Instead of a bold discussion on how to move NIH into the future, we have gotten staunch adherence to the status quo. COVID has shown that the status quo is unacceptable. I hope that more leaders in the research community will recognize this pivotal opportunity to develop which we have today does not reflect the best structure to achieve its mission nor the best structure for science. We should not shy away from this reality. And I would add that several of these reforms were suggested by the Institute of Medicine more than 20 years ago. I continue to look forward to the proposals, to your proposals to help the agency as it moves forward in this new Congress. And I want to thank you as the director for coming here today, especially in November, which is very unusual for us to have a hearing. But I now would like to yield to the ranking member, the gentlelady from Connecticut, who I have the honor to work with on this subcommittee, for any remarks that she would like to make.
Thank you so much, Mr. Chairman, for holding this hearing on the National Institutes of Health. My thanks and a very warm welcome also go to today's witness, Dr. Monica Bertagnolli, for appearing before the subcommittee today and for her leadership of the largest and most important biomedical research institution in the world. Dr. Bertagnolli, the first surgeon, second woman to hold the position of director of NIH, is a world-renowned expert on clinical oncology. And over her incredibly accomplished career, she has greatly advanced our knowledge on the genetic drivers of cancer. The millions of American families that are directly impacted by cancer are better off for having had Dr. Bertagnolli at the helm of the NIH. Dr. Bertagnolli has been laser-focused on ensuring NIH's life-saving research reaches more places and more patients, especially in rural communities. And she understands that health policy must be first and foremost based on science and data. And the American people are behind her. The American people do trust the NIH. Over 88% of Americans agree that basic scientific research that advances the frontiers of knowledge is necessary and should be supported by the federal government. I am proud of the broad bipartisan effort that has gone into building up this critical institution that brings hope to millions of American families, as well as patients around the world. From 2015 to 2023, on a bipartisan basis, the Appropriations Committee increased funding for NIH research by nearly 60%, from $30 billion in 2015 to $47.5 billion in 2023. For 2024, Congress passed another bipartisan bill to fund the NIH, supporting research into cures and treatments for cancer, Alzheimer's disease, ALS, mental health, maternal mortality, and protecting funding for so many other areas of life-saving research. We are a month and a half after the end of the fiscal year without a final labor, health, human services, education bill that can become law. This committee and this Congress should be focused on finishing appropriations bills before the end of this year. Some of my colleagues want to delay our work until well into next year by passing yet another continuing resolution. America is demanding change. They want border security, public safety, help with extreme weather, and natural disasters. Those are addressed by government funding bills, and continuing resolutions delay government getting to work. Forcing agencies to operate from continuing resolution to continuing resolution without consistent, predictable resources hurts the American people and worsens the issues we examine with each hearing. At a time when we must be able to quickly respond to crises at home and abroad, delay is irresponsible, dangerous, and a waste of taxpayer dollars. Democrats are ready and willing to negotiate. It is time for our Republican colleagues to come to the table. The president's budget also requests $7.8 billion for the National Cancer Institute, an increase of $615 million. As a survivor of ovarian cancer, I know I am here today by the grace of God and because of biomedical research. Promising advances in cancer research, including immunotherapy, continue to bring hope to millions of Americans facing a life-threatening cancer diagnosis. One of my top priorities as both chair and ranking member of this subcommittee is to address the mental health crisis in this country. Tens of millions of Americans struggle with mental illness and do not have sufficient access to mental health care. I want to know how research is helping to understand what it is that's happening in our brains or in our genes, and how science can help to prevent or treat mental illness. I look forward to hearing about progress in treating Alzheimer's, ALS, and diabetes, as well as advances in addressing maternal health, health disparities, and so many other diseases or health conditions facing millions of American families. For this subcommittee, it is our responsibility to finish full-year appropriations for health, education, and labor programs, including life-saving research at the NIH. Which brings me to the topic of today's hearing. The President's budget for fiscal year 2025 requests a total of $49.8 billion in discretionary funding for the NIH, an increase of $1.2 billion. Dr. Bertagnolli, I am very pleased to see the administration's proposal to boost funding for women's health, including your request to double funding for the Office of Research on Women's Health to more than $150 million annually. NIH-supported research has us on the cusp of curing endometriosis, and they are ramping up investments for menopause, which will ultimately impact half of our country's population. During my 4 years as chair of this subcommittee, I was proud to double the funding for the Office of Research on Women's Health, bringing it to its current funding level of $76 million. But there is still a long way to go. However, I want to be clear that I do not support the House majority's short-sighted proposal to overhaul the National Institutes of Health through the annual appropriations process. Any discussions to reauthorize the NIH needs to be bipartisan and bicameral, including both authorizers and appropriators. And it must be done through a thoughtful process to incorporate the best ideas to maintain NIH's position as the crown jewel of biomedical research. I look forward to hearing from Dr. Bertagnolli how she believes NIH can best be modernized to address our most serious challenges. As I noted at the outset, I am proud this subcommittee has always had a strong history of bipartisan support for the NIH. The health of our families and communities must always rise above partisan politics. I look forward to working with my colleagues on both sides of the aisle to ensure that the NIH remains prepared to face the next global health challenge. It is my hope that this subcommittee will resume an effort that began when I was chairwoman in 2019, which was to invite an additional panel of institute and center directors to testify. I value the research of every institute and center, and I believe it would be of great benefit to the subcommittee to have the opportunity to hear from others directly. Thank you again, Dr. Bertagnolli, for being here today, and I yield back.
Thank you, Ranking Member DeLauro. And at this time, we would like to recognize Director Bertagnolli, and we look forward to hearing your testimony.
Thank you. Chair Adderholt, Ranking Member DeLauro, and distinguished members of the committee, it is an honor to testify before you today. Let me start by thanking you for the funding you provided to NIH in fiscal year 24. I know you're facing a difficult year and appreciate the NIH funding you included in your fiscal year 25 bill. American taxpayer dollars that fund NIH go to every state in the union. Each year, NIH awards nearly, I could get closer. How's that? Sorry. Each year, NIH awards nearly 60,000
massive
new
landslides
grants,
crushed many
supporting more than 300,000 researchers at more than 2,700 institutions across our nation. We are proud to contribute to nationwide innovation in biomedical research, to be a tremendous engine for our economy, and to support the next generation of researchers who will meet the challenges of the future. Decades of sustained investment in fundamental science are producing exciting results. How can we replace a defective gene, thereby achieving durable remission of a debilitating disease? How do we enlist the specific function of the immune system to cure cancer or autoimmune disease? How do we develop replacements for vital tissues and organs to return function lost by injury or disease? Our laboratories are delivering answers to these questions and many more every day. One of our top priorities is to earn back trust lost during COVID. We need to better communicate information about the research we do and how it benefits all Americans. Several programs to do this meaningfully engaging people across the country, including the NIH Engage Initiative, the NIH Community Engagement Alliance, and Care for Health, a clinical research program for primary care providers and their patients, partnering with them in research that addresses their specific needs. Our work is urgent. This new network, involving all NIH institutes and centers, was stood up in less than a year. And in early December, we are looking forward to the first in-person meeting of investigators serving many rural communities. Going forward, we will broaden participation so that communities throughout the entire country can drive progress in health relevant to their unique needs. This nationwide partnership with the people we serve will go a very long way toward earning trust. NIH cannot meet its goals without integrating all that we learn from our laboratories, our clinics, and our communities. What makes this possible are data. We have data arising from a nationwide healthcare system linked through electronic health records. Researchers receiving the more than 60,000 brand new grants each year must make their data available for sharing with the broadest possible research community. That is a lot of data. And artificial intelligence has dramatically changed the way we think about its potential value. We must expand the National Library of Medicine to fully engage our partners, both within and outside of government, to advance data use, data analytics, and data science. We must put our data to work as the possibilities for discovery and health improvement are tremendous. We have so much important work to do. Families across the country are facing high rates of maternal mortality, struggling to care for those suffering from Alzheimer's disease and losing loved ones to substance use disorders. The 2025 President's budget represents support to address these critical needs, as well as many other important programs that I suspect we will discuss today. We know that we are not perfect. No agency ever is. We must continually to seek better ways to deliver what people need. We look forward to working with our newly reconstituted Scientific Management Review Board and with all of you to drive needed operational and administrative advances. NIH-supported discoveries have benefited all of us, and we are poised to do so much more. Your continued support of our mission to help all people live longer and healthier lives is crucial. Thank you for the opportunity to appear before you today. I look forward to answering your questions.
Thank you, Director, and we will start the questioning. We will have 5-minute rounds as usual, and I will begin, as I mentioned in my opening remarks, in coordination with the House Committee on Energy and Commerce. We've worked with, this subcommittee's worked in proposing or reorganizing the NIH's 27 institutes and centers. Each of the institutes would be reorganized with its own administrative function into 15 institutions. We all want the NIH to remain the world leader in biomedical research, and the agency must be able to adapt to changes in science and new health concerns. And I hope we can all agree that it's important to periodically evaluate organizations as large and as important as the NIH. Former NIH directors have noted that agency's sprawling structure can undermine its effectiveness. A 2003 report by the National Academy of Sciences Institute of Medicine, which Congress directed, said that the decentralized structure made it difficult for NIH to set up strategic programs involving many institutes or to support interdisciplinary research efforts. The report recommended merging some institutes and other organizational changes to help NIH respond to fast-changing science and research needs. My question would be, does the concerns about the NIH structure and recommendations, even though it's been known for more than 20 years, do you believe it is a conversation worth having? number one? And number two, do you believe that everything at NIH is working just as it should?
Oh, so first, we embrace change, effective innovation, development, and growth in response to our world, which changes all the time. We also embraced the recommendations of that National Academies report. One of the things that has happened over the last 20 years, beginning slowly and now dramatically accelerating over the last 2 years, has been a mandate that the different institutes and centers across NIH work together, work across the strength of the enterprise to conduct critical projects for which collaboration is essential. I'll give you a few examples. The Pain Research Center, across about 12 different institutes and centers. The Adolescent Brain Cognitive Development Program, Diabetes Prevention Program and Outcome Studies, the Brain Initiative, helping to end addiction long term, the Improve the Initiative for Maternal Health. All these are just a few of many, many examples where 10, 18, 20, sometimes all institutes and centers are working together. And I believe that that is incredible progress and goes a long way toward delivering what we need and meeting the needs, the very valid recommendations of the previous reports. The last thing I will say, and I've been public about this, my concern, really my main concern, over collapsing our institutes and centers is what we have had each of those entities be, is the touchstone for the community out there that cares about particular diseases. We have to earn people's trust, and we have to be visible representations of certain disease groups and constituencies. So, for example, the people who are worried about Alzheimer's disease, even though it's across all of H Project, know to think about the National Institute of Neurologic Diseases and Strokes and the National Institute of Aging. That's their touchstone. Finally, let me just say that I would be more than happy to work with you on needed reforms. I've seen things in the recommendations that I think, number one, we're already starting to adopt. They're great ideas, and many other things that we can work on together.
Thank you. I've got 30 seconds, so I'm going to go ahead and defer to my ranking member.
Thank you very much, Mr. Chairman, and thank you for your response to that effort, because I think it is, what I said in my opening comments, we need to hear from you on where you think it is in collaboration with others who are interested in making reform. I'm pleased to see that the recent $200 million in investment for interdisciplinary women's health research across the NIH. I came to the Congress, as you know, on wanting to work on health issues because of my own experience. And NIH has made progress on investing in women's health research, but as usual, there's always more work to get done. What strategies can be undertaken to increase the inclusion of women in research studies and the inclusion of both sexes in all preclinical studies? Where do we need breakthroughs in women's health? Where should we be targeting our resources to improve women's health?
Yes, thank you. And we have been, frankly, energized yet again by recent attention to women's health overall. So first of all, through the Office of Women's Research on Women's Health, we've long had an approach since the office has been established, again, of collaboration across every single institute. Mm-hmm. What we've done with this new emphasis is a complete reassessment of where we are with women's health and some of the critical areas where we're not doing as well, where we're not making progress as much as we need to. Mm-hmm. Maternal health, that's a big one. Some under-resourced areas of research that are really important. I think menopause is one, endometriosis, polycystic ovary disease, some of these conditions of women that we haven't made progress, but we are poised to do with more emphasis and interest. And We look forward to being able to focus on those more and implement. Lastly, in 2017, we had a mandate that every clinical trial, every clinical research project report the sex and of the participants. And we have seen what has happened. And actually, in the vast majority of our programs, we actually have more women than men participating in clinical trials at this, and a lot to
And the
do that we're eager
preclinical
to get
trials
to.
as well?
I'm sorry?
Preclinical trials, both sexes represented?
Uh,
Areas.
Preclinical trials, you're talking about fundamental biology before we get,
yeah.
yes, sex as
Yeah.
a biologic variable has been considered a very important part of all preclinical research as well. And some of the results coming out of that, because of that, are really exciting. We could talk
Really?
about that later.
Please, I would love to,
Yeah,
love to know more
very
about that.
exciting.
Thank you. Thank you. I pointed out in my opening remarks to highlighting the mental health crisis in this country. Tens of millions of Americans, mental health, most important health issue they face in their lives, daily struggle. What kind of progress are we making to help Americans struggling with mental health? What are we discovering about the brain or our genetics or environmental factors? How is the NIH ensuring that research discoveries are being translated into treatment and mental health care that's improving people's lives?
Yeah, we really have appreciated significantly the increased funding that has been provided to the National Institute of Mental Health in its role of coordinating across its strategic areas of understanding fundamental biology, the genetic and basis of disease, understanding the role of society in mental health and in support of vulnerable people, and then in the nuts and bolts of getting top quality mental health to everyone who needs it in the country. The other thing that, again, I'll just point out, the amazing collaborations that happen through the other initiatives, the BRAIN Initiative, being able to image has never before and get a physical and physiological picture of what happens to the brain in various mental states is driving truly exciting new research. Finally, public-private partnership and looking forward to working with our partners in industry on new treatments and new therapies. Let me just end by saying the two greatest areas of opportunity: better science giving us new opportunities for treatment and therapy, and society, better support of the role of community and society and health and care in being able to help people with mental health issues.
My time has run out. I got about 3 seconds, but thank you for your collaborative work with the Women's Health Initiative, and thank you for what you're doing in these areas. And secondly, it's wonderful to listen to you and the passion in which you talk about the science, the data, the research, and what exciting discoveries are being made. Thank you very much. I yield back.
Thank you, Chairman. And of course, Rosa, she's great because she's from Wyoming.
She's also Italian.
Doubly great.
It's a twofer.
Yeah, twofer. Thanks for being here, Doc. I appreciate you coming before the committee. A couple of quick questions. I don't know if the answers will be quick, but oral disease impacts nearly 3.5 billion people worldwide, ranging from disabilities for millions of Americans. Global oral health disease costs more than $710 billion annually, with the U.S. dental expenditures rising to $162 billion. These financial and health burdens show that researching oral diseases is a pressing public health priority. The National Institutes of Dental and Craniofacial Research, NIDCR, plays a pivotal role in advancing the health of millions of Americans by spearheading innovative research into oral, dental, and craniofacial health. How does the NIDCR contribute to advancing oral health research and improving dental care outcomes, and what makes its work so impactful in the broader field of healthcare? And are there emerging fields that the Institute is particularly focused on? And just to follow that up, as has been discussed this morning, the consolidation of the various institutes from 27 to 15 or whatever, I see that the NIDCR would be consolidated in a new National Institute on Neuroscience and Brain Research. I guess that's because the teeth are really close to the brain. Could you briefly talk about how this proposed consolidation might affect the U.S.'s premier standing in oral health research, and what would be the effect of this proposal on research budgets?
So thank you so much, Dr. Simpson. Well, let me just start by saying that none of us is healthy unless we have absolutely good oral health.
Yep.
I mean, it really is a harbinger of what's going on in your entire body. And, you know, I know this as a cancer doctor, you know, even. You know, one of the first things we do when we see our patients in clinic is what's going on in their mouth.
Yep.
You know, it lets you know if your cancer patient is doing well and if their body's doing well or not. I mean, that's just one example that really doesn't have anything to do with what people traditionally think of as the narrow lane that oral health fits in. So we don't think of oral health as a narrow field. We think of it as something that is really about and helps us inform all of health.
And let me just add,
Yeah.
being a cancer doctor,
Yeah.
isn't it true that there are an awful lot of the cancers that first express themselves in the oral cavity?
Oh, absolutely. You know, and some of the ones that we have the most control over starting to fix, you know, the ones I know of the best, you know, anything to do with toxins, tobaccos, any of the smoking, of course, everyone knows those, but many of the lymphomas in those conditions very first. I'll give you another example, infectious disease. So much about we're learning about response to infectious disease and how we can catch that quicker and understands what's happening to people. Again, craniofacial. Ways of getting insights into the immune system. What's going on with our immune system? Believe it or not, the tonsils. Well, you know. So there is so much going on there. And I'm also proud to say that really I would love to finally get over this, I think, unfortunate assumption that NIH is just a bunch of silos. I'm really proud to say that NIDCR works all across the rest of the NIH on these very issues.
Thank you. I appreciate that. I'm going to ask you a question I've always been a big fan of NIH. In fact, I think all of us on this committee have. It's been a bipartisan effort to increase their funding and stuff. I spent the first 10 or 15 years I was in Congress, I spent probably more time out to NIH than I did anywhere else, just because it's fascinating, the research that they're doing out there. Haven't been out there for a number of years, need to get back. But I think you had a fantastic reputation among the American people. As I'm sure you're aware, that's been damaged for right or wrong, doesn't really matter. Fact is we've got to get that credibility of the NIH back. What do you plan on doing to do that? Do you have a speakers bureau?
Well, we do, but we only have 14 minutes. Can I, to the chair, can I address this? Okay, very quickly. We do not get people's trust by putting out public service announcements. We do not get people's trust by saying, hey, we're smart, we know what to do, we're the scientists. We get people's trust by solving the problems they need to have solved. And yes, we need to do much more to communicate with people. This is how what we are doing is truly relevant to you, wherever you live. And also, this is why I'm so enthusiastic about both the data initiative and the Care for Health program, because we want to be, and we can be, in every community saying, hey, not only do we want to be here to serve your needs, we want to partner with you and have you be a person, you're the American public, be part of what we do at NIH. And we know how to do that.
Well, I hope so. And I've advocated for years that you ought to have an active speaker bureau across the country, because there's every Chamber of Commerce, Lions Club, Rotary Club, whatever, it's looking for speakers at noon. And you got researchers all across this country that they would be fascinated to hear what they're doing, but they need to be active out there saying, hey, we have this available.
Well, I think you might hear from your colleagues that, I've been director for a year. I've spent a lot of my time on the road, and I love it. Out talking to people is one of my favorite things to do. Anyway,
Thank you.
thanks.
Ms. Spokane.
Thank you, Mr. Chairman, and thank you, Director Bertinelli, for being with us. And thanks for coming to my district and meeting with folks at the Cancer Center. I learned a lot that day, and it's really great that our tax dollars are going to really advancing some great research in cancer. So I ask this, I think, of every NIH director every year. Is there any drug that you know of that's come to market in the last year that hasn't had support from NIH?
I can't think of one.
Okay,
No.
so I think it's been consistent like that. So we invest literally in every drug that comes to market. So then let me ask this question, and I often start with about margin rights, but let me ask it in a different way. Why is it that we, on average, pay 15 times the price for drugs in the U.S. than we do in Canada or Europe?
Well, I can't answer that question. But let me tell you what I'd love to speak to, which is what I think is the right way forward for this issue. Okay, we American public dollars go into this engine that generates this great economic output for our country. That's wonderful. What I would propose to do is that at the time of licensing a technology or whatever intellectual property that has been developed with NIH funding, with government funding, at the time of that licensing, we sit down with that company partner. We need them. We can't get these drugs to the people unless we work with them. But we sit down at the time of licensing and we have a discussion at the very beginning. Okay, how is this going to be accessible to the American people if you get this license? And being accessible means, you have to manufacture it. It has to be something that can't be only in one special location. Nobody can have access. And it has to be at a price that the American economy and our society can manage. And if we do that in the beginning, then we won't be doing the more destructive come after issues. And I think we should start that type of a plan immediately. We've done a lot of work into it and we're ready to go.
So when I went around to visit some of my rural hospitals, they told me how much prescriptions that were 6,000 went to 13,000 in the last year. All the other issues that are out there. There's one, Novartis, a Swiss pharmaceutical company, has a childhood muscular atrophy treatment that costs $2.1 million, and a lot of insurance companies isn't covering it. They got $500 million from NIH. So I love your proactive idea, but what do we do about something like that right now? If your child has a chance to live but can't have that opportunity because of the price that's set, insurance won't cover it, the fact that we're funding every one of these drugs but we don't have a better answer is honestly impossible for me to explain when people raise issues like this. What do you say to that?
So I am a passionate advocate that everyone should receive the benefits of what NIH has been able to contribute to, everyone who needs it. And I think an issue like this, I would be very proud to work across all of government to try to bring whatever knowledge we have at the NIH and capabilities to make that happen.
So because I ask this question every year, and every year I have to come back to it because it hasn't been solved, what can we do in the next year towards trying to solve this? Because, there's other drugs for sickle cell and for, I think it's hemophilia, or not hemophilia, it's a different one, but $2 and $3 million for a single treatment.
Okay.
Just having another conversation a year from now about this doesn't help the people that weren't helped in the last year. So what can we actually do right now to try to help on this?
Let me give you one for sure that we want to own at NIH. We've been working very closely with the FDA on this as well. Gene therapy for very rare diseases. No company is going to even do those. What if you're a parent of a child who's got this rare disease, and we know if we work hard, our technology will be able to cure that child? And the for-profit industry is just never going to do that. So one of the things that we are planning on, we're developing and have a program ready to go, is that we will start delivering more out of our pipeline of gene therapies for rare diseases. We will manufacture and test them within the clinical center at NIH, and then when they are ready for marketing and production, At that point, after everything is completely de-risked, we will hand them over to the for-profit sector with the absolute requirements that they be that the people who need them are able to access them. So what we've done is we've taken all the risk out of the development, so the companies can't say it needs to be $3 million because we had all this risk development. Well, we'll do it in a streamlined fashion, get it to where it's ready to be manufactured, and then hand it over with very strict terms that it has to be delivered to these people who need it.
Great. I look forward to continuing to have more discussion, but I'll yield back, Mr. Chair.
Dr. Harris.
Thank you very much, and thank you, Doctor, for visiting with us today and for visiting with me after your appointment to the NIH directorship. You know, I know it's, you know, we brag on the fact that we've, you know, raised the budget, but I hope everyone will agree that America's getting sicker, not healthier. Whether you look at mental health, physical health, life expectancy, maternal mortality, fact of the matter is whatever we're doing, it's just not working. And there's a reason why, you know, Mr. Kennedy and Mr. Musk are going to have a say in this, because I think they realize that we have to make America healthy again, and we have to do it efficiently. So I'm going to ask you a couple of things along those lines. First of all, we talked about indirect costs. Fact of the matter is, you know, in my agriculture subcommittee, we limit indirect costs to 30%, yet at NIH it's functionally limitless, including large endowed universities who actually are subject to the excise tax we impose. I mean, these are large. These are, you know, $500,000 endowment per student. We're still subsidizing their administrations, their overhead. So I would urge you to consider applying the same caps, which would allow, as we have in agriculture, which would allow us to actually fund far more research projects. And, you know, the university's got to get a little bit of skin in the game, more skin in the game than they have. Let me talk about nutrition and prevention, because this is something I have spoken with Mr. Kennedy about. You know, we have the attitude in America that Ozempic, I guess, is going to cure our nutrition problems. Yet we spend, in the SNAP program, for instance, $110 billion program, $10 billion on sugary sodas, and probably $5 to $10 billion on salty snacks. Yet when I had a hearing and we called over to the NIH to get someone from the Office of Nutrition Research to actually testify on this, we were told that you don't have a scientist at NIH who specializes in studying diet-related diseases. Is that true? I mean, you list Alzheimer's as a major cost, but you know obesity, hypertension, diabetes, these are the drivers of huge costs to our Medicare program. Do you really not have a scientist at NIH who specializes in studying diet-related disease?
Well, so I'm really glad that you brought up these issues, Dr. Harris, because you couldn't be more wrong. I mean, that perception could not possibly be more wrong. I mean, nutrition is fundamental to health. We all understand that. And I can't think of a single institute or center across NIH that doesn't in some way or form have research that touches on nutrition.
You're missing my question.
Okay.
In the Office of Nutrition Research, we were told you don't have a scientist at NIH who specializes in studying diet-related disease. Is that true, or were we told that because NIH just didn't want to get involved in this argument over the SNAP program? You'll have to get back to me because obviously you don't know the answer. That's what we were told. I got to tell you, Mr. Kennedy will probably change that over at NIH.
I believe that's incorrect, but yes, I will.
Well,
get back
then
to
you'll have to explain to my office why we were told that you don't have one. Because given the huge cost of obesity, hypertension, diabetes, cancer, which you know as a cancer specialist is diet-related, how you do not have that at the NIH, I don't understand, but it might be why, despite a $50 billion budget request, we're actually sicker now than ever. I don't know. The issue of trust of NIH was brought up. Now, you recently received a letter from House Oversight regarding a $9.7 million NIH grant after Dr. Johanna Olsen-Kenny, the medical director of the Center for Trans Youth Health and Development at Children's Hospital Los Angeles, told the New York Times that she plans to delay publication of her study, NIH-funded, because the multi-year study found that puberty blocker treatments for adolescents with gender dysphoria did not experience mental health improvements. Did you receive that letter?
I did.
Is it true that she's delaying publication of an NIH-funded study because I guess someone didn't like the outcome of the study?
I know the same thing you know, which is the article from the New York Times, and we have not seen a publication of that study yet.
So as far as you know, it's true what was published in the New York Times. You have no reason to doubt that the New York Times published exactly what a $9.77 million NIH grant recipient is delaying publication for, I will say, political purposes.
Well,
Is the position of the NIH that that's acceptable
so
for an
if you
NIH
will,
grant recipient?
I would really love to address this issue for you. First and foremost, NIH concentrates on science, not on politics. We actually have a mandate, an integrity mandate against political interference in our work. That is the law for us, and we abide by that completely. This particular issue, the particular issue of whether our grantees publish or not, we absolutely encourage our grantees to publish. It's also probably the leading criteria for them ever to get any funding in the future. If they haven't published on what they did before, they're not going to get funded again. But more important than that, there's two safeguards to make sure that the public gets access to data as a result of publicly funded research. And this is not an option for the individuals. They have to submit a progress report every year. And when their research is done, their data becomes the property of the public. It is U.S. government data and has to be shared appropriately with the biomedical research enterprise. So even if an individual, we don't compel them to publish, but even if they don't, we will have those answers to deliver for the American people and for you.
All I can say is the American people spent $9.7 million on that study. That study should be published because, as you know, this is what creates the doubts about the NIH. Yield back.
First of all, thank you so much for your good work and really for your attitude about progress. Very impressive. So one of the things that's concerned me is that there's been some talk by some of who might have leadership positions in the next administration of discouraging vaccination. And I know there are lots of diseases that children can get, and adults, hepatitis, RSV, can't say all of them, tetanus, the mumps, the measles, the chicken pox, all that. Could you tell me what would be the downside, I'll put it that way, if our children specifically were not vaccinated?
Yeah, thank you for raising this issue. So if you go back 100 years ago, the leading cause of death, and it was dramatic, was infectious disease. And why did that change? Vaccination. That is the single reason, vaccination. And it's been, even in my career, my lifetime, that I've also seen individuals who unfortunately were in the womb when their mother got rubella, terrible congenital malformations that happen. So it's not just the consequences even for the individual, it can be mother to child, and then finally, across society when we see the spread of infectious disease. So I don't think, in what we will see immediately, if all vaccination suddenly stops, we will see much more severe illness and death in children. But then within, it doesn't take too long where you have mothers who haven't been vaccinated and might get rubella. Look at what has happened. Look at what the scourge we had with polio. I mean, and then I'll also remind you all, look around the world. because there are other places in the world that have this, that do not have widespread vaccination of their populations, and look at the tragedies that we see there. So I think it would be very disturbing.
Yeah, well, I'll say thank you for giving me the answer. Sounds pretty alarming. So, 90% of pregnant women take prescription medication. Only 5% medications include data on their impacts during pregnancy. And I'm going to get right to my question. There was some recommendations in the 21st Century Cures Act, which set up a task force on research on pregnant and lactating women. What is NIH doing about these recommendations and handling this issue?
Yeah, this is a critically important issue, and total lack of data to help women and their providers understanding what is safe to take during pregnancy. We've worked very closely with FDA on this issue. The other thing that we have done is we've stood up a group within NIH that are pharmacologists and gynecologists who work on the issue of what do individual drugs look like? What do they think the safety, risk levels? What do we already know from what's data out there about when women happen to have been taking these? So gathering the data we already have and informing, then increasing the clinical trials participation of women, not putting the fear that if you be on this trial and these drugs, you should be excluded. But I have to say there is still one tremendous roadblock, and that is the huge concern over any trial that's being run certainly by the pharmaceutical industry over litigation if there is some untoward effect during pregnancy and their drug was being tested. So we can do everything we can to figure out what can be safe, how to care, and advocate for inclusion of women in more of these trials, but I think a real solution is going to take some kind of more security for the people who are, the companies that are at risk when they do these studies and are worried about litigation.
Real quick, we know that Medicare has been negotiating the lower costs of drugs. Hopefully that'll be implemented eventually, probably in the next year or so, I think. But what do you anticipate that means for the health of our seniors?
Well, I think anything that increases access to needed medications where we have great proof of benefit, anything that can increase access to everyone who needs it is going to be of great benefit. And this would be, certainly affordability is one of the issues with access.
Thank you very much. I yield back.
Thank you, Mr. Chairman. Dr. Bergantoli, thank you for being with us today. I sincerely appreciate your visit to our office. You and I have friends in the country who, like yourself, have been lifelong dedicated to the combating cancer. So I thank you for that endeavor and their endeavors in continuing that great fight that should be always non-political and nonpartisan. So I thank you. My question, Doctor, is my state, the great state of Tennessee, has been a strong part of all of the U.S. research program since its launch in 2018. With thousands of Tennesseans enrolled as participants, the drug program data and research center at Vanderbilt Health, and researchers from several Tennessee higher education institutions utilizing the data for health research. I'm pleased to hear of the progress made thus far. I would like to know how the NIH is taking advantage of this national resource and how it would be supported in the future. And I thank you.
So this resource has rapidly become a worldwide treasure. Why? Because it is the most diverse genetic data set that exists that ties people's genes to their health in the world. In fact, we meet with researchers from all over the world who have their own database. The UK researchers over here. Their research set is not representative of our country because it's not diverse enough. So the diversity itself is a tremendous benefit. and great value for the future for all kinds of things they're going to do. But there's one other reason why all of us is so priceless. It is everywhere in this nation, and it is people from every persuasion, every walk of life, every race and ethnicity, every socioeconomic status who've agreed to be a partner with NIH to do research. And if I can't think of anything that's going to get us further toward building trust than things like this, where we have 800,000 people who've said, I want to help you do this. And we have contact with those people on a regular basis. This is not a one-time thing. This is an enduring relationship that really shows the value of the work we do.
Thank you for your answer and appreciate your being here, and I'll yield back.
Thank you very much. I apologize for having to step out, but thank you again. And I will read your testimony, but I just want to say how much I associate myself with all the comments that have been made and the importance of your job, what you're doing, and NIH for the country and for the world, and specifically all of our constituents. And of course, there are many issues that I've been involved in over the years with NIH, which have been very important as it relates to the whole issue around racial and ethnic disparities. And so important. And I wanted to ask you a couple of questions about the sickle cell trait research, because it's very important, and NIH and very few had been focused on this, because there's a lack of understanding of the environment and the genetic factors associated with the sickle cell trait. Now, a couple of things. One is it affects 1 in 12 Black Americans and 1 in 100 Hispanics in the United States. I introduced House Resolution 672, which calls for sickle cell trait research, evaluation, and public education and awareness. And a couple of things which I learned over the years, and I still haven't been able to get NIH to move forward on. One is that when babies are born, there are sickle cell blood tests conducted to determine whether or not, especially if they're targeted, ethnic populations such as African American Black children. They're tested at birth. By the time they become of childbearing age, they don't know whether they have the trait or not. You have two people with the trait having a child, that it's 50% chance that that child might have the disease. And why in the world is not a part of a battery of tests for people who are more susceptible to having the trait? I mean, and just on a personal note, I didn't know I had it. And someone said, well, you better check because, if you have children, that child could have the disease. And so what is it about this research that has not been done that we need to learn about, that you all need to be able to move forward to make some decisions about how to make sure that, Hispanics, Black people, people who are more prone for sickle cell disease get tested at childbearing age as part of a battery of tests? Because who knows if they have the trait? The parents don't even know.
So I really appreciate this these insights, because it's a part of, even a much bigger issue, right? What's our health? It's the genes we inherit, and it's the environment that we live in. It's our communities, it's our environment, it's our nutrition, it's all of these things. And what we need to do is to understand those relationships, being able to uncover when we know there is something that introduces risk in people, and being able to get, when we have that, those goods and services out to.
But we already know that two people with the trait, the research has been done, two people with the trait have a 50% chance of having a child with the disease. We know that.
Correct.
So why don't we do something about it?
I do think that I do agree with you that when we know we have a risk assessment like that, that then has implications for how people should be treated, then we need to work with the care delivery and public policy arena to make sure that our useful data is acted upon.
But I guess what I'm trying to wrap my head around is why you know that. Won't NIH come forward and say, look, we need to make sure that in a battery of blood tests, that there's some, whatever strategies you use for labs and for physicians that make it a requirement, or at least ask people, do you want this? Because of the risk factors of having children with the disease. I just can't figure out why, because we don't need to start with the research. We know that.
I think we can always do better on the implementation side of everything that we do, and I think you raise a very important issue that we could start, considering. And I will say that this is one specific issue that's very important, but we have many more.
Yeah, no, I understand, but this is really cost effective. We're trying to find a cure for sickle cell disease, and when you are able to prevent it, then you would think that we would be doing that as a priority.
I will say, along with the other the other discussion we just had, that the All of Us program has wonderful return of results to all of its participants, and sickle trait is one of them. So we're proud of being able to do that in a research format, at least.
Yeah. Again, it's part of the racial and ethnic disparities that need to be highlighted and prioritized because it really affects Black people, people of color, and it's not been a big priority of you guys.
Thank you, Mr. Chairman, and good morning, Director. I saw recently that NIH issued a consensus statement regarding premature infants and necrotizing enterocolitis in concert with the FDA and CDC. The statement said there was no conclusive evidence that preterm infant formula causes NEC. I wonder if you could talk about why it was important to make that statement and how we ensure that preterm infant formula manufacturers remain in the market.
Thank you for that. Yes, very important issue. There was some significant concern that use of these formulas had a higher risk of necrotizing enterocolitis, which can be lethal in little premature babies. Clearly, our data shows that mother's breast milk is the best. And if you look, the studies that we are aware of show that a mother's breast milk for a premature infant protects them better than these formulas. I don't think there's a debate about that. But there's debate about what do you do if the mother can't produce breast milk. Now you've got a baby who has to take, frankly, second best. And second best are these developed, manufactured products. There has been some concern, and I know some lawsuits that have been, that have introduced a lot of challenge over babies getting these formulas and saying, well, they have a higher risk of necrotizing enterocolitis, but when there's no other option, what are you going to do, right? And so we are bringing, their National Institute of Childhood Health and Development has brought all of those data and is working with FDA and with HHS on solutions that will help protect, indemnify, do whatever we need to do to make sure that those formulas don't go away. Because the last thing I'll say is those companies don't make a lot of money making those formulas. It's really a wonderful thing that we have them available.
Okay, thank you. I also wanted to bring your attention, something that was brought to my attention from a Michigan family made me aware that a child suffered from FSGS, and I'm not even going to try and pronounce the name of the disease, but it's a rare kidney disease that damages kidney filters, allowing waste from blood to impede kidney function. And people who have this untreated can progress to end-stage kidney disease or nephrotic syndrome, often leading to kidney failure. that leads to a kidney transplant. And unfortunately, the people with this disease, the kidney transplant doesn't cure it, and often, that doesn't work at all. And so I'm wondering if you're doing any work on improving treatments for those suffering from FSGS, anything being done to improve diagnostic treatments, therapies, anything in that range?
So that particular issue I can't speak to, but I can find out because there are many rare diseases.
Sure.
But I think you also heard my previous answer.
Yeah.
I think NIH needs to take even these very rare diseases under our wing and really champion the gene therapies that can be ideally curative for these individuals. I'll point you to one thing that I think is incredibly exciting. We have a researcher who is doing in utero gene therapies. Wouldn't that be wonderful if we could test a baby even before it's born, deliver a treatment, and eliminate suffering from things like this? And we
Well,
really want to be a part of that.
I was intrigued by what you were talking about, the biomedical research on rare diseases and the desire to, because there's risk involved and not a lot of profit involved for a business, that you're working towards developing these therapies, maybe even pilot plants or manufacturing, testing them. I think that's very encouraging to hear, and I would love to learn more how I can be supportive of that.
Well, thank you. And I think I'm sending the message that we are responsible for everybody, and we really have to be here for what the private sector can't do. Leave to the private sector what they will do, absolutely, be their partners, totally, but if they're not going to do it, we can't abandon these patients and these families.
Thank you very much, and I yield back.
Good morning, doctor. Thank you for being here. First of all, let me just say I'm a cancer survivor, and that was because I was detected early because of all the wonderful work that's been done in research. My parents both died of cancer, but I'm a survivor thus far, so I'm grateful for that. But I am concerned that other folks aren't as fortunate as I am. And so there's a couple of things that I've talked to the NIH about is access to clinical trials, particularly for African Americans, have been under-resourced, underrepresented. Wanted to know, what have you done? What are you all doing? What are you committed to increasing the diversity of those clinical trials? Also, the grants that are awarded for the research in our communities has been, in many instances, under-resourced and misunderstood in terms of its value. So another thing that I've talked to the NIH director about had been, how do we diversify the question as to what grants are going to be awarded. And then my third area, since I want to get all my three questions out, but I do want you to answer them, has to do with cancer research and the fact that young people are dying of cancer earlier. And in particular, African Americans are experiencing, both men and women, colorectal cancer earlier. And because there's no screening for them, by the time they know about it, it's too late. What is it that your research is showing you that you all need to be doing, or we all need to be doing and supporting to change that situation?
Yeah, well, certainly, thank you for that. Let me let you know that I'm also a cancer survivor, and the reason I am here and healthy and expect to live a full, long life is the work of the NIH, frankly. Wow. That's what did it. So I'm there with you, and I will tell you that so first of all, we have teams across all of NIH that can provide input into this problem, but we need a coordinated, dedicated approach to get our work everywhere it needs to be. And that is my big intention and hope for the Care for Health program. Like I said, it got started up in only 1 year. The goal is to do clinical trials research using primary care doctors in the primary, and this speaks to the early detection and the screening and the young people and why didn't we know? We got to get to by the time they're in an oncologist's office, it's way later than we want to be. And there's so many things that impact cancer and all these other diseases, obesity, activity, nutrition, all of those things, that lands in the primary care's office. So that's why we've launched this program. We are standing it up at 3 hubs that are reaching very diverse rural communities right now. And my dream is to see that research engine across this entire nation focused on the places where people are doing badly. We have the haves and have-nots in this nation. And this research network needs to be where people have significant disparities.
Do you have measures of improvement in terms of the diversity in the staff that you hire that gets to make these, decisions about where things happen, where what doctors are going to be involved, what research is going to be? Because what we found was that there was a lack of diversity, and with that lack of diversity came a lack of understanding of the significance of some of the work that we thought needed to be researched in communities uniquely affecting us.
So I can tell you that our approach is that we go into these communities, which have great diversity in their population and in their communities, to serve diverse people. And we go in and they become our partners. They become part of the decision-making process. Frankly, they tell us what research they find most meaningful and they want to do. So it is really, this new program is tailored to every community we come into. We can do this. We're all of NIH. We have 27 institutes and centers. So we can tailor what we do to whatever a community tells us their need with the people, the primary care community, and the people, the supporting members, faith communities, you can think all kinds of public service organizations that are local, and bring them into the process of developing the research. It's really, I think, exciting, and I'm so pleased to see our first investigator meeting in 2 weeks.
Thank you, Doctor. I yield back.
Thank you. Thank you, Chairman Adderholt, for holding this hearing today. Dr. Bergtinoli, our national debt just topped $36 trillion, and this committee has made the tough but necessary decision to propose historic reductions to NIH's budget, as we have done in other areas, to help get our fiscal house in order. We need to be as efficient as possible in all areas. And one area that your agency has a deeply concerning track record on is transparency and accountability. In July of 2021, the National Archives investigated the unauthorized disposition of HHS Secretariat records. And on July 10th of 2023, an investigation was opened regarding NIH officials using personal email accounts. Now, NARA's Inspector General is investigating similar issues within NIH. Are you familiar with this investigation?
Yes, I am.
Okay, great. Well, in this letter, it says that a senior scientific advisor used a personal email account in an apparent effort to evade the strictures of the Freedom of Information Act. Now, it also asks in paragraph 2, it says NARA requests that NIH investigate these allegations of unauthorized disposition of NIH email records, and it asks, please provide a comprehensive report within 30 days detailing NIH's findings. So my question to you is, have you responded to NARA?
So I can unequivocally say that it is completely unacceptable to violate our laws and all the principles of NIH by inappropriate management of public records, which are crucial, and by the activities that you listed here, completely unacceptable. For the specifics of the issue you refer to, I cannot comment on ongoing personnel matters within our agency.
Ma'am, this is not necessarily a personnel matter. Congress is an investigative body. We are doing an investigation here, okay? So your response to us has nothing to do with an ongoing investigation of some personnel matter, all right? When I ask you a question, I need a response. So the question is, have you responded to the Office of the Chief Records Officer of the United States government regarding this breach of law? It asks for a 30-day, it asks for a response in 30 days. Have you responded or have you not? Because the investigation is still open. I mean, it is still open, and it's been, I mean, you've been the director now over a year. This letter was sent 4 months before you became the director. So this has been now a year and 4 months.
We're talking about a different matter than I understand if it is something that has been around for a year and 4 months.
It has
So-
been. This letter was dated July 10th, 2023.
Okay, so I will have to, first of all, absolutely, we take our responsibilities to Congress for your right to receive our records and to make a timely response to your requests, but I will have to look into this matter. and get
Okay,
back to
well,
you.
would you please respond to this committee with this information? Because this NARA investigation is still open. It's been a year and 4 months. You've been the director for a year. And we have no indication that there has been a response from NIH yet.
I will look into this matter.
Okay, thank you. Now, do I have your commitment that, that NIH, because of this issue, all right, now, has NIH implemented any sort of specific protocols to preserve documentation, which has been, or which in the past has been deleted, all right, to ensure that we have a seamless transition with the incoming Trump administration?
Absolutely. We abide by all the legal requirements for retention and preservation of our public records.
Okay, so I have your commitment that absolutely NIH will be complete and open with the incoming administration and will preserve all records.
Absolutely.
Okay, thank you very much. I yield back.
Thank you very much for being here. I want to ask you some general questions. First of all, we've had very few hearings about an agency on which we spend $50 billion. 10 of the 27 institutes and organizations that you have account for about $40 billion, about a little less than $40 billion of that. Cancer being the number one. IAID and others having similar numbers, but lower than the Cancer Institute. Would your directors of at least the 10, who account for about 80% of the spending, be willing to testify before this committee regarding the fiscal year 26 budget when it comes up next year?
I'm sure they would.
You have been, as I recall, the only witness that has appeared on behalf of NIH in the last fiscal year. Is that correct? Or the last calendar year?
We had a Senate hearing where I was accompanied
meant
by
to
my
the
colleague.
House, though.
No, to the House, I have been the only one, yes.
So that we haven't heard from any of the other directors of the 80% of the spending that occurs. Mr. Chairman, I think that's an oversight responsibility that we have. And I would hope in the year to come, as we have in the past, that we would have much more extensive hearings and not at the last minute as this hearing is occurring now as we come close to ending the congressional term this year. Secondly, I want to have you talk a little more about Dr. Harris's conclusion that the health of Americans is worse. I talk in the context of the three leaders who served this House for 20 years, all in their 80s, and all doing pretty well, mainly because of the healthcare system that we have in this country. Mr. Natcher used to say, if you take care of the health of your people and the education of your children, you'll continue to live in the strongest and best country on earth. That's why we invested in NIH. We invested in national defense as well, of which I've been a supporter every year that I have been here. But we lost 1 million people to the pandemic. We lost 500,000 people to World War II. So that our investment so that our investment in NIH is critical to the health and national security of our country. And I think, Mr. Chairman, frankly, it behooves this committee to have much more extensive hearings with respect to this expenditure of money and the critical impact it has on the health of our people. Lastly, because I'm sure I got 2 minutes. I've always been worried about the decline in the pay line of our extramural payments because it adversely affects incentives for young researchers to go into basic biomedical research, which is the central, critical, important point in long-term health. Would you discuss briefly or explain to me briefly where we are on pay lines in the various institutes?
Yes, the institutes and centers range from, around 10 to 12 to a high of 20s or low 20s in their pay line.
And what would be the optimal?
Well, that's hard to say. All I can tell you is unequivocally, we leave brilliant work on the table every single year, and because of those lower pay lines.
Let me interject. In the course of the service on this committee, and I went on this committee in January of '83, the pay lines have at times been in the 30s.
Correct.
With the scientific community judging that at least 3 out of 10 of the requests and applications are good science. Would you agree with that?
Oh, absolutely. Yeah.
Mr. Chairman, I would hope that we would have a hearing on that because what I'm concerned about is China, Japan, Korea, Europe is a more welcoming environment in some cases for our young researchers. And if we lose our young researchers over the long term, we're going to be very adversely affected in terms of the quality and extent of our research on health issues. Again, I would point out we lost 1 million people to the pandemic. We lost 500,000 people to World War II. We need to invest in stopping both of those. But I disagree with Dr. Harris. Very frankly, I think some of the statistics that are present today are based upon our population and some of the changes that have occurred in our population. And there is no doubt that we have a healthy community which has access to affordable quality health care, which knows what to do, how to keep itself well, and a population that does not have that information, and that has skewed, therefore, life expectancies and health incident reports. And we ought to look at that as a committee, I think, to see whether or not the overall statistic really bears resemblance to what is actually happening on the ground. I think, unfortunately, we have essentially 2, maybe 3, maybe 4, maybe 5 Americas in terms of access and quality of health care. And we need to look at that. Thank you. My time has expired.
Thank you, Chairman. And thank you, Director Riccinelli, for being here with us today and for coming to testify. I'm specifically interested today in hearing from you, Director, and how you have worked to increase engagement on women's health matters, as well as what has been done to include more Hispanic representation in studies, particularly in research dealing with Alzheimer's and cancer. And it was already asked in general terms on women's health, so feel free to touch on that if you want to, but because it's already been covered, I'm going to jump right into the second part here of what I mentioned. Thinking specifically about cancer, the University of Arizona is a Hispanic serving institution, proudly hosts a comprehensive cancer center, where currently research is being done to understand how cancer, like breast cancer, lung cancer, or ovarian cancer, are specifically impacting Hispanic communities. What is the NIH doing to support these endeavors, and what does the NIH need to ensure recruitment and retention of women, especially from those underrepresented groups, into clinical research?
So, yes, thank you. You hit such a core topic and principle for me. You know, biomedical research has to include everyone, and it matters okay? We're the genes we inherit, but we're also our society, our environment, where we live, what we eat, our culture has profound influences on health. So including diverse cultures, like I know the Hispanic community is how many different diverse cultures, right? It's certainly not a monolith either. This is why I don't think we can really do our job unless we bring our research inclusively to really every community in the nation. This sounds like something that couldn't be done. It absolutely can be done in a very positive way. I'll say it again. We have a plan to do this with the Care for Health program. And the last thing I will say in there is I fully expect that not only will this program give us the data we need that says this is how a Hispanic community in Arizona is different than a community in northern Montana in respect to what we need to do for health. It will also, in those parts of the United States that really have poorer health and poorer health care, raise the quality of their health and their health care because we are in there doing research. If lots
Well,
of
I'm
research saying that.
definitely focusing, hoping on that as well. When it comes down to finding those, getting those findings, and regarding the efforts you're already working on, what timeline around that are you looking at? When can we get some of this information?
Well,
'Cause I've asked Secretary Becerra about this as well, and I get a positive response and an openness and optimistic engagement, but I don't know if I've seen actual progress or data on this.
Well, as I said, we stood up this new community research enterprise. In 1 year, we're having our first investigator meeting in 2 weeks to launch the
Okay.
studies. And we're launching studies that that are already ongoing, that these communities will participate in, just to really supercharge it, to get it running and start getting results immediately. And those studies will be about what the communities need: pain, nutrition, substance abuse, maternal health, all the core issues that those communities need.
Okay, let's jump into something that also impacts the group that I'm talking about here directly, switching to Alzheimer's. I've been learning a lot about this disease. I've been working very closely with my community in Southern Arizona on this. I've jumped with both feet in on helping here and doing something about this. My neighbor was recently impacted by this, my neighbor's wife. So it impacts, once you really start paying attention, it's out there way more than I think most realize until you start really looking into it. So researchers, again, at the University of Arizona estimate that by year 2060, the Hispanic population will at least double the size, and that the Hispanics are about 1.5 times more likely to be diagnosed with Alzheimer's or dementia. So what is the NIH doing to understand these trends? And also on that, what can we do to ensure that the Hispanic and Latino populations are being sought and included in these clinical trials also?
Yes, so Alzheimer's disease, incredibly complex issue that lots of generous funding coming to the NIH has really helped us take an incredibly comprehensive approach, okay? And this is our mantra. It is the fundamental science. What are the genetics of Alzheimer's disease and how do they affect people's risks? What is the environment and what are those contributions? And critically, and use those tools to develop new treatments, but not ignoring the role of prevention, right? You can't start managing Alzheimer's disease when somebody is 55, 65, and they're already exhibiting symptoms. We have to be able to detect it so much earlier and to intervene with people at risk far before to prevent them or at least ameliorate the symptoms that they have, keep them healthy and thinking and with us as long as possible. So there are efforts across that whole spectrum. And I will say, I also have an iron fast commitment that anything we do in the development of these new therapies will get to every single community.
Thank you. And thank you for that answer. Out of time, Chairman. Thank you.
Thank you, Mr. Chair. Thank you, Director Bertignali, for being with us today. According to the Department of Health and Human Service Office of the Inspector General, about 80% of NIH funding goes to support research grants. including grants to foreign organizations. In 2002, NIH awarded approximately $257 million in funding to 224 foreign grant recipients. As I'm sure you're aware, a report released by the Office of the Inspector General last December found that the vast majority of foreign grant recipients failed to complete and submit even the required annual audit reports, making it impossible for the NIH to effectively monitor these foreign grant recipients. The report found the NIH did not receive 81 of the 109 annual audit reports for foreign grant recipients, and for 7 of the 10 audit reports that required follow-up actions, the NIH did not follow up. What policies or procedures have been changed since the release of this report? This is an appropriations committee. I think we have responsibility to the American taxpayer to demand accountability for the money that NIH administers.
Oh, absolutely. And my response is we've been working very closely with after the results of the Office of the Inspector General audit to strengthen our oversight. We have taken measures for those who are in noncompliance to penalties for noncompliance, which means withdrawal of their ability to receive funding from the U.S. government, and we'll continue to take this very seriously. We expect our foreign grantees to comply just as rigorously as do our domestic ones.
And so thank you for the response, as generic as it might be. I'd certainly intend to follow up and ask for more specifics if you'd be able to share those.
We would be happy to provide it.
And given these recent challenges and the fact that funding recipients include foreign governments with their own strategic interest, are applications for research grant support from foreign organizations treated the same as applications from domestic organizations, or are additional oversight and transparency measures put in place?
There are investigation and oversight that have to do with the ability of of any grantee, but this particularly applies to foreign grantees, to have the policies and procedures in place that would allow them to fully comply with all our laws, rules, and regulations. So any organization, whether domestic or international, has to have federal assurances that say, if you're going to get this money, you have to follow all the rules. And those same stringent requirements apply to foreign grantees.
So the same standards apply. Wouldn't you agree that a foreign entity should be held to a different standard than one domestic?
I'm not sure, so I think that our policies should be equally stringent no matter where our federal money is spent, and that is the approach that we take.
I can tell you that I believe that money that we send abroad should be scrutinized in a far, far different way. Next question, and as I'm sure you're aware, rural populations are historically underrepresented in clinical research and often experience poorer health outcomes. North Carolina has one of the largest rural populations in the nation, and my district has some of the most rural counties in the state. Given this context, how does the proposed budget ensure that rural populations are incorporated into the research?
So the proposed budget includes funding for the Care for Health program, which is focused entirely on rural populations and making sure that the entire breadth of all 27 institutes and centers of NIH have an infrastructure and can bring their research to rural populations. And we're very excited to get that started immediately.
Thank you, Mr. Chair. I see I'm out of time, so I'll yield.
And what we're going to do now is we're going to go to a second round we still have a little bit of left time before the noon hour, so I'd like to reduce it to 3 minutes in our questioning. So we will proceed with that, and I'll begin. Congress has provided $4 billion for the Advanced Research Projects Agency for Health, better known as ARPA-H, since it was created back in 2022. ARPA-H was designed to be distinct from the National Institute of Health from how it designs its programs to streamline processes for funding high-risk, high-reward programs. ARPA-H's program managers are also subject to term limits, and the research teams that program managers oversee must meet regular performance metrics or risk having their work stopped. Given these agencies' sizable budgets and the need to be good stewards of federal taxpayer dollars, I'm concerned about the possibility of duplication between ARPA-H programs and NIH research. The question, how does NIH coordinate with ARPA-H to ensure that agencies are not duplicating research efforts, and what processes are in place to prevent duplicative efforts overall?
So, thank you. We have a formal process for avoidance of duplication of funding. It begins when a study is proposed and gets carried through when any award is made to ensure that there is no duplication of funding. And I'd be very pleased to share that formal policy with you.
Okay. Thank you. The 21st Century Cure Act was enacted back in December of 2016 and has funded large-scale NIH efforts such as All of Us research program, Advancing Precision Medicine, the Brain Research through Advancing Innovative Neurotechnologies, better known as BRAIN initiative, and the Cancer Moonshot. And we have known since the law passed that this funding would eventually wind down. Indeed, the cures funding for the National Cancer Institute's work related to Cancer Moonshot research ended with FY 2023. The All of Us and the BRAIN initiatives ended with will end in FY 2026. As the NIH looks forward, could you elaborate on what the agency is thinking regarding these initiatives? Has it contemplated which it would find valuable to continue and find space within its broader NIH budget versus using the research and insights gained from those efforts, but letting the program end in its current form? If you could address that, please.
Yeah, so I think it would be extremely unfortunate to let any of these three programs end because they have been tremendously beneficial, productive, frankly, exciting every single day. You've heard me talk about the virtues of the All of Us program. I mean, BRAIN initiative is benefiting so many, it's benefiting Alzheimer's, every aspect of neurodegenerative diseases and neurologic diseases in such an exciting way, and it's very unique. It's bringing a lot of new capabilities to NIH. So, and then finally, you know, the Cancer Moonshot has really spearheaded new initiatives such as the Childhood Cancer Data Initiative, which was really critical. So, critical programs, we cannot let them die because they have done amazing work. And, you know, if our budgets are flat or we are forced to figure out, you know, how do we replace these fundings that disappear, we're going to have to make some really difficult decisions. But they're critical. I don't want to let them go.
So you're committed to both of those?
Well, I will say that we are going to have to make some incredibly difficult decisions. I think they're high priority for us.
Thank you. Mr. Laurel.
Thank you, Mr. Chairman. I'll try to get in as much as I can. There was a question I want to ask, which is your support for ALS through the Expanded Access Program and through public-private partnerships. But I want to follow up on something that Congressman Molinar started to talk about, and that is the recent NIH, CDC, FDA consensus statement about the benefits of donor human milk and the potential benefits of human milk-derived human milk fortifier for very low birth weight infants. I'm focused on increasing the access to donor milk breastfeeding supports while pushing for federal regulation of the industry. as there currently is little federal oversight in this space. I sent a letter this morning to the FDA asking what their agency is doing to ensure that parents as well as medical teams are adequately informed of the potential risks that some preterm infant formula could pose for very low birth rate infants, benefits of donor human milk, and suspected benefits of human milk-derived human milk fortifier for these infants. What actions are NIH taking to disseminate the information that a, quote, diet containing human breast milk appears to be protective against the development of NEC? The use of human milk-based fortifier in the infant's diet rather than bovine-based fortifier may be useful in reducing the development of NEC. Do you see a federal need to focus more efforts on the human milk-derived, human milk fortifier in light of recent concerns that bovine fortifiers may not be protective against the development of NEC? And Abbott and Rickett Benckiser, the only two manufacturers making this fortifier, are threatening to exit the market following a series of legal challenges.
So yes, thank you for that. In fact, I had a conversation about this particular issue just last evening with Commissioner Califf. Here's what we know. Mother's breast milk is the best. The babies die unless they get the the manufactured formula we have, if they don't have mother's breast milk. We don't know about that middle ground that you're referring to. We don't know how effective donor milk is. You know, there's lots of storage issues, lots of issues, and then also better formulations. And so that is an area that deserves much, much more research as quickly as we can.
On the human milk and fortifier versus bovine,
right?
Which appears to be. I'm not a scientist, but I would welcome the view that this has more of an opportunity to create an NEC.
Bottom line, we need more research there in that intermediate.
So I would love to continue that conversation. I have 9 seconds left, Mr. Chairman. ALS, Expanded Access Program.
Yes, tremendous work going on with the Accelerated Medicines Partnership together with the Foundation for the NIH. That gets us with our with our pharmaceutical partners and gets us a relationship, gets us working on research together, gets us developing new drugs, and we are also committed to work on expanded access for this population.
Look forward to working with you on
Yep.
that. Unfortunately. Thank you, Mr. Chairman.
Dr. Simpson.
Thank you, Mr. Chairman. Again, thanks for being here today. Let me ask you just kind of a question that was spurred by Dr. Harris and by Mr. Hoyer about health outcomes and stuff. I was told when I was having a conversation with Dr. Collins when he was head of the NIH that what we've become good at is finding treatments for diseases. We're not nearly as good at finding cures. So consequently, we have a lot of people who years ago would have died off that are still in our society. I should have died 50 years ago, the way I've behaved. But it's, I've had both my knees and my hip replaced, my neck had surgery, and every time I complain, my wife says, shut up. She said, 50 years ago, they'd have just taken you out in the corral and put you down. So we're having more people live longer with diseases that we've been able to treat, but not necessarily cure. What does that do to the statistics of whether we are a healthier society or a less healthy society?
Oh, there is no question that we look at aging and our goal of healthy aging as and how that goes together with longevity. Okay, quickly, our life expectancy. Why is our life expectancy going down as a country? It's not because older people are not getting older. It's because younger people are dying before they have a chance to get old. That is really tragic. And, there's a lot of National Academy of Science did a really nice report about this just, about 4 years ago, showing it's the diseases of despair, it's substance abuse, it is poor nutrition, diabetes, untreated hypertension in some populations, frankly, kind of in the middle of the country, in many places, rural communities that have been left out. So that is the life expectancy issue. Now, you've added another layer, which is how do we keep people as they get older healthy and active and thriving? And I think it's not just about cures. It's about making, obviously, prevention. First and foremost, prevention needs so much more attention. But then also, when we do get the understandable natural processes of aging, being able to develop more affordable, accessible, straightforward approaches to keeping people healthy and active a long time. I could
appreciate
talk about specifics of what they are, but we don't have time, and I'll happy to do it later.
I think this issue is the biggest one facing our country in the future. Because what it's going to cost for older people to stay, and the days when kids or parents raised their kids and then the kids took care of their parents, those are kind of gone. And trying to find care for those senior citizens is going to be a huge issue in this country in coming years, if it isn't already. Thank you.
Ms. Lee.
Thank you very much. A couple of things. Let me just follow up on the issue of sickle cell trait and just ask a question you may need to get back to me on. This committee years ago helped me move forward to look at the A1C test as it relates to those individuals with the sickle cell trait. We learned, and NIH had the research, but it never had been made public, that if an individual has the sickle cell trait, the A1C test that is used for diabetes could give a false positive. And I knew one physician, for example, who was treating an African-American patient for diabetes when really they didn't have it because they had the sickle cell trait, didn't know they even had the sickle, didn't even know should ask. So I just want to find out at this point, have you all looked at now what types of tests? I mean, the A1C may have been modified to the point where now it doesn't matter, that it's moot. But also, I knew there's fructosamine tests and others that once we expose this and once we got NIH to get on top of it, labs and physicians, we did an outreach public awareness campaign to say, look, don't do this if a person has a sickle cell trait, but no one knew if they had a sickle cell trait. So going back to that. So I'm just wondering now, the A1C test, have you all looked at that as it relates to those with sickle cell trait, and is it modified now, or is there still some gray area that we need to look at?
Yeah, so I'm not a hematologist with expert in sickle cell trait, so I would have to get back to you on the specifics of that issue. But in general, I can speak to what we were talking about before as well as now, that NIH's job is to do the very best research in this population, so that we know what the best care for them will be, and then to present that data, not bury it, present it to the regulatory agencies that then start taking the actions that you
NIH,
need.
finally, when I got to the bottom of this after a couple of years, NIH said, oh yeah, we learned this in the 70s, and it was like there, or the 80s. And no regulatory agency, no lab, zero in terms of making sure that the information was provided.
We
So
will
you all
work in
did do the research, and you knew it, but nobody else knew it. So I look forward to getting the response, because we still are working on this. Also, just with regards to the importance of food as medicine and the rigorous research, and that's a national program that I initiated, and I want to thank you very much. I'm just wondering if you're looking at the cost benefit analysis of this in terms of budget implications, because we've learned through pilot projects that funding food as medicine initiatives really does help reduce the cost of healthcare.
Oh, yeah, and it is also frankly, one of my favorite programs, because nutrition is absolutely critical, and it's so personal, and so I'll just give you quite tiny little
cost impact
and
of that,
cost
though,
impact
also.
is amazing. I'll just give you one tiny little impact. We recently, I visited the Chickasaw Nation, where they had been doing some work with returning to their native foods and planting a garden. Talk about low-cost solution for this, planting a garden and growing their original native foods. And it's going so well, and so
Yeah,
I'm
and I just
thrilled
want to make
do that
sure
work.
NIH is documenting the budget implications of this so that we can look at that in context of taking it to scale.
Yeah.
Thank you very much. And
I will yield back. I thought I took my entire time. Thank you very much.
thank you very much. And I appreciate your further comments on, whether America's getting sicker or healthier. I'm just of the opinion, I look around and I know a lot of people understand that it's not getting better. Anyway, two issues. One is, during a previous subcommittee hearing, I asked Dr. Volkow if it's a bad idea to allow recreational marijuana to be fully legalized while we still have so many outstanding clinical questions. She agreed it's probably a bad idea. And you may or may not know, because I think you came on board after this, but was the National Institute of Drug Abuse consulted before the decision was made by HHS to recommend that marijuana be rescheduled from Schedule 1 to Schedule 3?
I do not know the answer to that
Okay,
question.
thank you. We heard a little bit about, women's health, and I'll ask you the same question I asked Dr. Collins last time he appeared before the committee. Because I guess with Dr. Fauci's departure, you're America's doctor now. That's what the head of the NIH should be, and should be respected for scientific judgment. You made the statement that sex is a biological variable, and to me, having studied it, it's pretty clear, yes, it is, because there's actually a difference between men and women. And it's a basic biological difference. It's genetically established. And so I'll ask you the same question I asked him, because you said that your grantees have to report the sex of participants. So is there any advice on let's say you enroll a biological 47X or 46XY man in the study, but they claim they're a woman, so they get entered as a woman. Well, how are they reported to NIH with the study results?
So it would depend entirely on what question we're asking. So let me, scientific answer. It's very important. There are very important differences between people who have two X's and an X and a Y. We've fascinating result
Hundreds of
recently
genes,
about
I get it.
autoimmune disease, right? So cool. Okay, and there are also, genes and society. There are also people who might have an X and a Y, but they consider themselves a woman. And our research would consider both. That's a different situation. If we're studying a question about what is the relationship, let me be more clear. Let's say we have somebody who's an X and a Y, but now they consider they're a woman, and they are now, because they are considered a woman, want to be considered themselves a woman, want to use female hormones. We are very interested in that would be a situation where we would want to know
I
what
understand
their genetics
that,
are
but
and how we would.
in which group are they assigned? It's a very simple question. In which group should they be assigned? How should you assign an individual who was born, whose sex assigned at birth was one based on genetics, and what they think they are now? Where do you assign them?
We assign them according to the biological research question we are trying to answer. That's why, we're not going to say they're a man, they're a woman. We are going to base it off of science and the scientific question we're trying to answer. And if we're trying to study a transgender woman, meaning XY chromosome, but they consider themselves a woman, we will assign them according to the question we're trying to answer.
And that's why nobody trusts the NIH anymore. I yield back.
Thank you, Mr. Chairman. I guess if I couldn't pass a farm bill or appropriation bills, I'd ask questions like maybe anyway. But I guess I do think that there's more we could do around drug pricing. And I think the fact that we're paying 15 times on average what they do in Europe and Canada is an 800-pound gorilla we're ignoring. It's in the room and we're just ignoring it. And we're doing great work on research, but I really think if there's any way to figure out how to work more, maybe you find one company and do some marching rights for the first time ever to make a point. We just need to do something, or else we're just going to be paying way too much. So I just want to say that because every year we have the conversation, every year we don't make any movement on it. And I really think that, real people are concerned about that. My mom was one of those people cutting pills in half because she couldn't afford it. Real people go through that, and we're not doing them any good you know, in a fairly affluent community like Washington DC. So having said that, I just want to say I also really want to stress the importance of the All of Us program, which I know you're very aware with, and you came to my district to talk about that. Just concerned on some of the cuts I saw in that. The question I do want to ask, though, is President-elect Trump's potential nominee for HHS recently made a comment about he would fire and replace 600 NIH employees on day one, and that he thought we should take a break from researching infectious diseases. Can you just address those two comments? What would happen if you lost 600 people on day one, and what would happen if we quit researching infectious diseases kind of randomly? What that would mean?
Yeah, so quickly with my time, let me just say that the people of the NIH are such an incredibly valuable brain trust. You know, they, number one, I explained, they award 60,000 new grants every year to 300,000 researchers, 27 institutions. That is an amazing enterprise to get out the door. And I would argue with, very few hiccups, frankly, and do that every single day. So that workforce itself is just priceless and an engine toward all of our progress and to our economic advantage. The other thing is their deep content knowledge of the entire field of medicine and the relationship with the industry is just irreplaceable. Okay,
Infectious disease, real quick.
Okay, now infectious disease very quickly. I will go back to people died. That was the leading cause of death, and we are facing some serious threats. I mean, look in the news today. H5N1 is scary for us. And we are all over risk assessment mitigation, working with our other federal agencies to make sure that we can protect and mitigate anything that happens with that virus doing something evil. And we cannot afford to let down on that. People will die.
Great. Thank you. Yield back, Mr. Chair.
Thank you again, Mr. Chair. Director, the Department of Health and Human Services Office of the Inspector General has identified closing contracts timely and in accordance with federal requirements to be one of the long-standing challenges at the NIH. Closing contracts is generally the last chance for the government to detect and recover improper contract payments. On June 20th of this year, the Office of the Inspector General released a report titled NIH Did Not Close Contracts in Accordance with Federal Requirements, resulting in increased risk of fraud, waste, and abuse. Of the 30 selected contracts totaling $2.1 billion that the report reviewed, NIH only met closeout requirements for one contract totaling $140 million. For the remaining 29 contracts totaling more than $1.9 billion, NIH did not meet the closeout requirements, which seems like a gross misuse of taxpayer dollars. What steps or recommendations have been taken since the release of that report to improve NIH's ability to close contracts?
Well, thank you for that. We really appreciate our work with the OIG and that this issue has been raised, and we have been working diligently since that came out to resolve all of these issues together with them.
Would you mind telling me a little bit more about what working diligently means? Specifically, what
I
could
could
this
follow up
committee-
with you on this. I don't have it available to me right now, but I can follow up with you on the specifics of the significant progress that has been made since that report came out.
All right, I'm going to include that in my written request as well. And honestly, I'm surprised that with this level of, I'm going to use the word negligence, that the director of the agency responsible would not have more firsthand knowledge. I'm really disappointed in that. With that, Mr. Chair, I yield.
There we go. I want to follow up on what Barbara Lee and also Mr. Pocan referenced, and I think we all feel, and somewhat the tenor of the questions that are made. I've been on the committee a long time. In the 80s, Dr. Lowe was the director of NIDR. Dr. Lowe made the representation, I'm not sure when NIDR was started, when the first year of that institute. But he said that in that year, that calendar year, we had saved more money than had been invested in the entire life of NIDR. Part of that was fluoride, obviously, but other improvements that were made in both diagnosis and treatment of oral health issues. I don't know whether you have your comptroller or whatever looking at that, but what I think you heard here from the skeptics, but we ought to all think of this, is making sure the American public understands the extraordinary return they're getting on this $50 billion. Because that is a huge amount of money. We do have a budget problem, but if we don't know, if the American people don't know what they're getting in return, how many years of life, how early detection on cancer, the difference it makes both in the lives of individuals and the economics of theirs and the country's. So I would urge you to sort of have somebody in the operation looking in that and do what Dr. Lowe said. Hey, yeah, we're asking for, I don't know what it was at that point in time, maybe $120 million, $150 million. He said, but very frankly, all the money for all the years, however many years it was, you get back in 1 year because of the reduction of risk, the reduction of disease, and the reduction of cost. So I just use my 2.5 minutes to urge that we try to respond to these because they're legitimate issues and they are subject to demagoguery.
Yeah.
And if we don't have that information, those of us who believe that this is an investment that is probably as good an investment as we make.
So I can give you two figures that I know of today. One is that the return on investment for $1 of NIH funding is estimated at about $2.50 to our economy. So that's not bad. Not a bad ratio. Just the new grants given out this year, remember, there's grants, there's old ones that are already there, but just the new ones this year award new roughly 500,000 jobs, and that's just the people who receive the grants.
Right.
You know, what
That's
about
the-
all the support people and everybody else?
That's the economic country.
The economic.
That's certainly one part of it. But the bigger part of it is saved by people not dying. What is saved by, Alzheimer is an extraordinarily costly
Right.
incident in America, both in dollars and in the extraordinary burden on caregivers. So what I'm looking for is really, how much did we save because 10,000 people didn't die? How much do they pay in taxes because they didn't die? How much worth they did? So I think, yes, the economic consequences are substantial. You spend $50 billion, you have a geometric effect on your economy. But you also have the avoidance of additional costs. Thank you, Mr. Chairman.
Thank you, Ms. Hoyer. And for closing remarks, I'd like to recognize the ranking member, Mr. Laurel.
Thanks very much, Mr. Chairman. I have just a couple of comments, actually several comments. If we can investigate the pharmaceutical companies, we can deal with the pricing, Mr. Pocan, and we need to be willing to do that and deal with March and Rich.
Before Ms. Pocan.
Sure.
Of course, all those European countries or countries around the world, they have price controls. But by the way, the pharmaceutical companies obviously believe that there's some benefit in them still selling their product in places that have price controls.
Yeah, well, again,
Excuse me.
need to be taken on, full-throated about that. Secondly, and to follow up something that my colleague, Mr. Hoyer, said, and he's right in this, and I make it plain and simple. If you can't get them on the humanity of what you're doing, let's see if we can get them on the economics of what you are doing. You said that the NIH is not perfect, but let me just state this. Your record of supporting life-saving cures, treatments, diagnostics, and vaccines is unparalleled in human history. In human history. And if we stop investigating infectious diseases, plain and simple, people die. People die. Now, maybe that's not of importance to some folks. They're not just going to be sicker, they are going to die. And that needs to be said loudly and clearly in this environment that we are in. Thank you, Dr. Bertagnolli, really, for being here today. Thank you for your leadership of the NIH. I am so proud of the subcommittee's history of broad bipartisan support for NIH research. We are a month and a half into a fiscal year, and Congress should be focused on finishing the appropriations before the end of the year. Going from continuing resolution to continuing resolution is irresponsible, and you want to talk about a waste of taxpayer dollars? Focus on the delay for 3 months, 6 months, 8 months, a year, what some people are speaking about. Let's get it straight on the use of taxpayer dollars. And for the NIH, I want to enact a full-year appropriation bill. I want to do it by December 20th, and we can get it done. All four corners of appropriations believe that we can get it done, so that what we're able to do is to continue to fund cancer research, women's health, mental health research, research to develop treatments of cures for so many diseases and health conditions that face millions of American families, and they're relying on us to do something. And your research at NIH brings hope to these families. The health in our families and communities have to be above partisan politics. And I urge my colleagues to continue a long-standing bipartisan support for the life-saving NIH research that you do, and that we need to push for what we're doing and get things done by the end of this year. In human history, we haven't made a difference in the way that the NIH has, and we thank you for that. Thank you.
Well, thank you, Dr. Bertagnolli. It's great to have you here today. We do appreciate your service. I think it's been a very good hearing today, and calls attention to some issues. I think while we may disagree on some things and we'll call attention, I think it's helpful to make NIH better. And so thank you for your work, and look forward to continuing to work with you. And at this point, the hearing is adjourned.